Uh, Hi guys. So today's topic will be splenic anatomy, which I want to finish real fast because I have so much medicine to do. So let's get going. So in splenic anatomy, the thing is, in spleen, the questions, the topics that are important, I've written splenic abscess, splenomegaly, hypersplenism. Okay, wait. I tell you, most important is indication of splenectomy and complications of splenectomy. Then we talk about in complications, overwhelming. Uh, Post-splenectomy infection, splenic trauma, splenomegaly, splenic abscess, function, storage, and hypersplenism. Okay, so most important is indication of splenic trauma in that, and then followed by complications of the trauma, which is OPSI, then splenic trauma, complications of that is splenectomy, then we have splenic trauma, infarction, abscess, splenomegaly, and some other questions. Okay. Uh, so let's start with it. Describe the surgical anatomy of spleen. Let's go with short questions first. We like those, right? Spleniculi. So spleniculi is explained here. It's accessory splenic tissue. Let's go spleen. Spleniculi is nothing but accessory splenic tissue. It's most commonly located at the hilum. Hilum. And if splenectomy is done for indications such as hematological, like ITP, lymphomas, malignancies, all that condition, it is very important to do exploratory surgery to actively search for any splenicular accessory splenic tissue, and a very close differential diagnosis will be. So cover this. Okay, so in the hilum, whenever we have any hematological conditions, we should actively search, because in case it is left behind, it can lead to recurrence. That's it. A very close differential diagnosis, splenosis, which is uh, splenic tissue found in other places, splenic particles present in other places following trauma. A very close DD axis, splenicosis, splenosis. Okay, so splenicular done. Splenomegaly causes. Uh, So splenomegaly, I think this is a very common question in medicine. So we have Kala Hazar, we have lymphomas, we have accessory splenic tissue. They're found in 10 to 20. They're found near the hilum, tail of pancreas, splenic ligaments. In case of disease like hemolytic anemia, thrombocytic, all these accessory have to be removed along with spleen. Okay. Wandering spleen due to this one, loose ligaments that was seen in house. Then, what is the next question we have here? Splenomegaly causes. If it's not here, it's fine. Splenomegaly causes an SRB itself, so let's just quickly look at that. Splenomegaly is 672. So let's see, where are you? Splenomegaly, yeah. Causes of splenomegaly: infectious, blood, metabolic, portal hypertension, collagen diseases, malignancies. Okay. Sometimes you can write about splenomegaly like clinically splenomegaly cannot be detected unless it's like 3 to 4 times the normal size. Then clinical features we can say it's an enlarging mass, your inability to hook your fingers under the costal margin, inability to insinuate your fingers under the costal margin. It's directed towards the right iliac fossa because its phrenicocholic ligament prevents its downward displacement. Then yeah, what are the causes of splenomegaly? We have infective causes. The most important infective Kala Azar. Blood diseases such as leukemia, lymphomas, ITPs, hereditary spherocytosis, hemolytic anemias. Metabolic causes such as amyloidosis, Gaucher's disease, porphyria. Portal hypertension, more commonly left-sided portal hypertension, also called sinister portal hypertension. Malignancies such as Hodgkin's lymphomas, splenic sarcomas. Okay, so splenomegaly, some medicine points you can write definitely. Med points, it's right iliac fossa, should be like 3 to 4 times, 3 to 5 times enlarged, and all that stuff. Then what are the causes? In infective, we have malaria, kala azar, typhoid, hydatid cyst, why not? Abscess. Then we have blood diseases such as myelodysplastic syndrome, Hodgkin's lymphoma, leukemia, hemolytic anemia, hereditary spherocytosis. After that, we have malignancies such as Hodgkin's lymphoma, chronic myeloid leukemia, chronic lymphocytic leukemia, all those leukemias. Yeah, idiopathic thrombocytopenia is also there. Malignancies. Then we have splenic sarcomas, rare. So infection, blood, malignancy, abscess, important. Metabolic, portal hypertension. Metabolic like Gaucher's, Niemann-Pick, all that stuff. Gaucher's and amyloidosis. We have portal hypertension, more commonly left-sided. And then we have collagen diseases. These are the causes of splenomegaly. Done. Then splenectomy indication and post-operative complications. Very commonly asked question, very important. So splenectomy. So let's go back where we are. Yeah. So splenectomy. There's splenectomy. Yeah. Indications for splenectomy. This is a very nice page which is taken from Bailey. So it should be in my mind forever. Trauma, onco. See, hot portal, hot portal malignancies, okay? Hematological, oncological, trauma, portal hypertension, and malignancies. Oncological only it will come, no? Yeah. So, what do we have here? Where are we? Splenectomy. Investigations, diagnostic peritoneal lavage, plain X-ray, and then we go for emergency splenectomy. Emergency splenectomy, splenography, partial splenectomy, and non-operative. So this table is very important. So splenectomy, Splenectomy always indicated in cases of tumor and hereditary spherocytosis. Okay, usually indicated in hypersplenism, in ITP, in case of splenic abscess, sometimes indicated in case of splenic injury, which is unstable patient, autonomic hemolytic anemias, in case of Hodgkin's disease with anemia, TTP, myelofibrosis, Wiskout-Aldrich disease. A predominant presence of thrombocytopenia epistaxis combined B and T cell immunodeficiency causes eczema. So X-linked disorder wherein there is features of thrombocytopenia, eczema, and I don't think that we've done a very good job at describing Wiskott Aldrich here, but okay. Rarely done in case of sickle cell disease, ferritis, and all that. Okay. So what are the hematological indications for this one? We remember, just remember, hereditary spherocytosis, hypersplenism, and purpura. Okay. Purpura, idiopathic thrombocytopenic purpura. These conditions occur due to development of autoantibodies against patient's own platelet. Now, it decreases platelet count. The spleen is probably responsible for sequestration and for production of antibodies. Okay, other causes of purpura can be aplastic anemia, decreased production, increased consumption, DIC, increased destruction in case of SLE, infectious pneumonia, or like ITP is there. Increased capillary fragility, steroid induced or Hinoch Lowland purpura. Okay. Types we have acute and chronic, longer than 6 months, and acute in about 2 months. Clinical features in it's more common in female because it's an immunological condition. Purpuric patches. Ecchymosis refers to skin discoloration due to extravasation of blood. Okay, are found on the buttocks, and petechial hemorrhages are found on the limbs. They are dependent areas that have high intravascular pressure. Okay. Apart from this, all types of hemorrhages are common and can be mild or moderate. 26.5. Common types of hemorrhages: epistaxis, menorrhagia, hematemesis, bleeding gums, hemarthrosis, hematuria. Intracranial hemorrhages found in some cases can be cause of death. Spleen is just palpable small size. Hess tourniquet test is possible. More than 20 petechiae in a circle of 3 cm diameter in cubital fossa, suggestive of purpura. Investigation: BTA will be prolonged. Uh, APTT, PTT will be normal. Platelet count is reduced. Bone marrow biopsy: precursors of platelets are increased. Okay, treatment. Spontaneous regression occurs in most cases. Short course of corticosteroids is beneficial. Tablets prednisolone is given. In adults, splenectomy is indicated in following situations: when it's lasted for more than 6 months, when ITP has relapsed in spite of steroid therapy, the patient is given a trial of prednisolone. Uh, Patient count rises within 7 days of starting steroid, after which splenectomy can be done. Surgery in ITP can be done when platelet counts are low. Ligate splenic artery first, and then we do. I said spleen should be removed, otherwise it leads to spleniculi. No, yeah, spleniculi, yeah. Maybe required 2/3 of patients will be cured. 15% will show empty remain will not benefit. There's a 70 to 80% of patients respond permanently and do not require any further treatment. Hemolytic anemia results from an increased RBC destruction which occurs in the spleen. The lifespan is shortened, hence respective hemolytic. These causes can be benefited from this one. Anemia, jaundice, and spleen are the triad of hemolytic anemia. Yeah, this Viva. Simply, hemolytic anemia we can have, jaundice can we have, splenomegaly we can have. Hereditary spherocytosis, autoimmune hemolytic anemia, thalassemia, sickle cell disease, yeah. What is the question? Indications for splenectomy. Okay, so the indications for splenectomy will divide into hematological indications, in which we have hereditary spherocytosis, idiopathic thrombocytopenic purpura, uh, acquired autoimmune hemolytic anemia, thalassemia, sickle cell disease. Okay. After hematology and hypersplenism. After hematological, we have hot oncological. In oncological, part of en bloc recession. In case of cysts, oncological conditions, diagnostic and therapeutic. Hemangioma, angioma, lymphoma. Yeah, part of N block is in esophagogastrectomy or upper carcinoma of stomach. Okay, or in carcinoma of spleen or in carcinoma of this one. Then we have trauma. In trauma, we have most commonly in cases of. See, we have done it very nicely here in this chart. Yeah, in cases of stage 4, stage 5, or stage 3 unstable, uh, stage 3, stage 4, stage 5, or stage 3 with unstable vitus or severe splenectomy. Uh, really like surgery, man. I really wish I could have done more here, but I don't know. Let's see. So we have ITP, we had hemolytic anemia, hereditary spherocytosis, autoimmune hemolytic thalassemia, sickle cell disease. Then we have hypersplenism. Then we have in oncological condition part of end block recession in case of esophagogastrectomy, in case of gastric carcinoma or carcinoma talar pancreas, in case of upper carcinoma of stomach, in case of lymphoma, in case of angiosarcoma of pancreas, in case of hemangioma, in cases of lymphoma is very important. Hairy cell leukemia, this one. Lymphoma is the most common. It used to be removed as a part of staging laparotomy. Now it is rarely removed. Okay, so this is oncological. Then trauma. Trauma we have stage 3, stage 4, and stage 3 with stage 4, stage 5, and stage 3 with unstable vitals. Then we have in cases of portal hypertension when there is esophagogastric varices. Fine. Then in cases of storage disorders. Then in cases of portal hypertension, in cases of hematological again, myeloproliferative diseases, then tropical, then infection. In infection, what and all we're going to write? We're going to write about hydatid cyst. We're going to talk about traumatic cyst, congenital cyst, septic abscess, Felty syndrome. Okay. And so if you get a question on indications of splenomegaly, just remember the headings of this one. That is hot, malignancy, infection, hypertension. Okay. So in H for hot, hemat, we have ITP, we have hereditary spherocytosis, we have autoimmune hemolytic anemia, we have sickle cell disease, we have sickle cell disease, autoimmune hemolytic anemia, we have hereditary spherocytosis, thalassemia. Okay, hemat over. Then onco. In onco, in oncological, we have CML, we have a part of N block. N block in cases of a part of esophagogastrectomy or carcinoma talar pancreas, all that stuff. Then we have lymphoma, hemangioma, carcinoma stomach, CML, AML. I don't want to miss this, bro. Come on. Okay, fine. Hairy cell leukemia. Hot. Malignancy was done. Storage will do. Hot, store, infection, hypertension. T trauma. Trauma in stage 4, stage 5, and stage 3 with unstable vitals. This can be intraoperative or accidental. Then we have storage. In storage, we have Gaucher's disease, Niemann-Pick disease. Done in case of Gaucher's disease. We also had others, bro. I don't know where it's gone. Yeah, but like CML, Gaucher's, Viscout-Aldrich syndrome. Okay. Apart from onco, then we have storage, then infection. In infection, we have abscess, we have hydatid cyst, tropical splenomegaly, traumatic cyst. Okay, infection. Then chronic infection or chronic malaria and all that. Then hypertension, most commonly left portal hypertension. It's called sinister hypertension. Okay, so these are the indications of splenectomy. In this, I would definitely want to mention one more thing here in case of variceal surgeries. Yeah, an infection also seen in Felty syndrome. Okay, here. Splenomegaly, neutrophilia, and this one, rheumatoid arthritis. Seen in case of splenomegaly, neutropenia, and rheumatoid arthritis. Okay. After splenomegaly, leg ulcers heal quickly, and neutropenia also improves. Uh, yes, okay, 26.32. Do we have a lovely Cushing features, Felty syndrome. Okay, indications these are. Then we go for procedure. You have those 5 steps: dissection of spleen from attachment, lateral attachment, retroperitoneal attachments. Then we have transection of spleen at hilum because the blood vessels are where gets attached here. Then dissection of spleen from gastric, short gastric vessels, and then removal of spleen. Okay, procedure 5 steps from book. Then post-op complications. This must be written in order. We have hemorrhage, reactionary, and return. Complications of splenectomy. Come on, bro. The early complications, we have pancreatic injury, vascular injury. Okay, so most common is hemorrhage. In hemorrhage, we have primary and secondary. In primary is during surgery, and secondary is reactionary. This is most commonly due to slippage of ligature, most commonly around the splenic artery during operation. So 24 to 48 hours later. Hemorrhage over. After that, we have injury to pancreas, pancreatic injury. This is seen in a good like 6% of the cases. And how do you know? This occurs because tail of pancreas. Why? Because tail of pancreas is closely associated with the spleen. What do you see? We see fluid rich in amylase. Okay. Manage conservative. Conservative means we check the vitals, we check vitals, hematocrit, and 24-hour CECT repeat. Okay. Next we go injury to stomach, injury to bowel, that is. Bowel or greater curvature of stomach. This is to avoid to have careful dissection techniques during short gastric artery ligature too close to stomach. Injury to stomach, it is repaired in 2 layers. The lower pole, it is also repaired in the similar manner. Okay, injury to bowel can be seen. This can present as hematemesis. This also needs to be managed conservatively. Management. After hemorrhage, injury, and this one, we come to the most common complication, that is pulmonary complication, that is atelectasis and pneumonia. Okay, so the fourth one and the most common complication is left lobe, lower lobe atelectasis and pneumonia. This occurs POD, post-operative day 1. Okay, so this can happen when adhesions are present between spleen and, okay, wait, they are common complication. They are the most common complication. Okay, it can range from minor cough to atelectasis and pleural effusion. Basal atelectasis is one of the most complication post-operative. This one very very important. Paralytic lelia is fine, leave it. Then hematological changes. In hematological changes, we have hematemesis can occur to gastric mucosa, fine. Hematological changes, thrombocytosis and thrombotic complications. Sometimes it can be dysphagia in persist as abdominal pain was confused for incision pain, gastritis. Ultrasound examination is a must. One of our patients had portal vein thrombosis, which is managed by anticoagulants. Okay, it can lead to in hematological changes we have two. We have transient and permanent. So we have transient and permanent. So in transient we have it is for 2 to 3 weeks, wherein most common one is increase in platelet, which can lead to thrombosis. Okay, this is managed by prophylactic aspirin as well as ITP. In ITP, platelet transfusion is done only after splenic artery ligation. Plus in ITP, platelet transfusion is done only after splenic ligation. Okay, now in permanent we have Howell bodies, basophilic stippling, reticulocytosis, and hypersegmented. Okay, from textbook from notes you read. Fine. This is hematological. Then we have most important OPSI. Overwhelming post splenectomy infections. Okay, I don't know if it is mentioned here. This is very very important. Okay. Anyway, OPSI is the most important. OPSI, I'll just write the heading so that you know. What is the full form? When it occurs 2 to 3 years after this one. What are the organisms? That is encapsulated organisms. Then we have in kids. Then we have, it is more important in cases of a hematological condition where we do actively search for recurrence than trauma. This is because in trauma some part is remaining. Very important, prophylactic antibiotics and vaccination. Prophylactic antibiotics we give penicillin and penicillin or amoxicillin for 2 to 3 years afterwards, and we give vaccination. In vaccination, most better one is pre-operative vaccination, two weeks before splenectomy is done. And then in pneumococcal vaccination has repeated 5 years, influenza vaccination has repeated 10 years, and a pneumococcal vaccine can be given anytime after 2 years of age. Influenza meningococcus, any age you can give. Uh, yeah, that's about it for OPSI. Fine. So this is splenectomy, lovelily done. What is OPSI? OPSI is overwhelming post-splenectomy infection. Full form. When does it occur? Usually occurs in the first 2 to 3 years after splenectomy. Which are the organisms implicated? We have pneumococcus, meningococcus, H influenza, which are basically encapsulated organisms. It mostly affect kids more than adults. It's seen more commonly in hematological splenectomy than traumatic splenectomy, because in traumatic splenectomy, active search for accessory spleen is not, splenecula is not done. So some part of spleen remains, so the function remains. Then what is the prevention? Prevention is vaccination, prophylactic antibiotics. Vaccination most commonly done 2 weeks before splenectomy, preferable than post splenectomy because titers will be higher in that case. Then what are the vaccines you give? Pneumococcal vaccine, H flu influenza, and meningococcus. Pneumococcal vaccine can be given after 2 years of age and repeated every 5 years. H flu influenza and pneumococcus can be given at any age. H influenza has to repeat it every 10 years, and prophylactic antibiotics of penicillin or amoxicillin up to 2 to 3 years post splenectomy. Okay. And in cases of dog bite, yeah. In cases of dog bite or cat bite, we can have infection with capnocytophaga. Phaga. Okay, that's it. Then we go to splenic abscess. So splenic abscess occurs due to infected septic emboli from otitis, typhoid fever, or even due to thrombosis of splenic vein causing infarction, followed later by infection. Okay, tuberculous abscess of the spleen is usually affected secondary to abdominal abscess. So the causes of splenic abscess: salmonella, paratyphi, spleen, labor, purpura sepsis, ear infection, nose, necrosis of pancreas, infection of bone, and chronic TB. Okay, so splenic abscess, when it comes, what and all you have to write? You have to write causes. Its first thing is immunocompromised patient. The first point you have to write. It's seen in immunocompromised patient. Second point is what are the predisposing factors? Predisposing factors are uh, hypersplenism, infarction, otitis media, pancreatitis, typhoid. What are the causes? Predisposing factors and causes. Causes is nothing but spleen, splenic, okay, chronic TB, necrosis, pancreas, infection, bone, ear, labor, purpural sepsis, purpural. P for paratyphy, S for salmonella. Here important, very important. Come on, predisposing factors for septic abscesses in secondary to infarction. First point. Then we have ear infection. I already mentioned that. We have hypersplenism. Then we have secondary to pancreatitis. And then we have typhoid fever. It has high mortality and it presents with abdominal pain, fever, pruritic pain, and splenomegaly. Investigation clinical features book. Then investigation of choice CECT. If it is unilocular, then we do pigtail catheter insertion. If it's multilocular, we do splenectomy. Okay. If it is unilocular abscess, we do pigtail catheterization. If it is multilocular, we do a splenectomy. Fine. Done, 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 done. So this is a splenic abscess. Next question is tropical splenomegaly. Fine. Tropical splenomegaly is due to malaria, Kala Azar, or schistosomiasis. Since this is endemic in tropical countries, it's called tropical splenomegaly. So it's defined as pancytopenia in the presence of normal or hypercellular bone marrow. Okay, it usually involves red pulp expansion. It must be remembered that in cirrhosis of liver, 15% of patients develop hypersplenism. Anemia and thrombocytopenia are mild. Rarely requires this one. The indication for splenomegaly is gross enlargement of spleen and hyperspleen indication for splenomegaly in these cases. Okay, so we go for tropical splenomegaly. Tropical splenomegaly is splenomegaly due to splenomegaly is basically Splenomegaly is tropical splenomegaly type of it has splenomegaly and hypersplenism. Hypersplenism is this one. It's pancytopenia in the presence of normal or hypercellular bone marrow. Okay, that also you should. Pancytopenia in the presence of in normal or hypercellular bone marrow. Okay, so in tropical splenomegaly, tropical splenomegaly is because of infection with like kala kala azar, and schistosomiasis. Basically, infections in tropical countries. In tropical countries, massive splenomegaly and hypersplenism are indications for splenectomy. Okay, this much is done. Yeah, tropical splenomegaly done. Functions of spleen. Functions of spleen is encapsulated here. Ready? Yeah. Immunological filter, pitting, hematopoiesis, and reservoir function. Okay. It's called culling. Production of lymphocytes, plasma cells, antibody production, white pulp, immunological response, reservoir of platelets, immune function, removal of RBC production in fetal development, and removal of antibody. So, in immunological function, functions of spleen, we have immunological. In immunological, we have antibody production, WBC production, then humoral response. Then we have filtering and pitting. We also have something called culling, which is removal of abnormal age damaged RBC. Age damaged RBC. Production of RBC fetal. It has acts as a reservoir for platelets RBC, WBC. Uh, reservoir and filtering of Heinz bodies, all that stuff. Okay, as much is enough. Functions of spleen. Next question: splenic rupture clinical features. Cause of splenomegaly already finished, no? Infection, blood diseases, malignancy, metabolic, portal hypertension, collagen disease, amyloidosis. Right? Splenectomy indications, post-operative complications, hypersplenism is remaining, splenic rupture is remaining. So splenic rupture and splenic trauma. Yes, splenic rupture is the most common type of this one. Splenic rupture is the most common type, most common organ ruptured, most common abdominal organ ruptured, most common rupture in children. Okay, when to suspect? Do we have it here? Complication of splenic injury. Clinical presentations important. That was the question of clinical features. Okay, so when to suspect? When we have 9th to 11th rib, then when we have bruising over left chest wall, chest wall. Then when we have curse sign. Curse sign is on when raising this one, left lower limb, the blood accumulates under the left diaphragm, which left dome of the diaphragm, which causes irritation of C3, C4, and this pain is referred to subscapular, suprascapular nerve C4. Okay, so C3, C4 dome of diaphragm, which gets referred to C4 suprascapular nerve. Okay, no, don't worry, just keep pushing. Then balance sign, blood in the vicinity of spleen is fresh blood which is coagulated, and blood in the periphery is not coagulated. Hence, there will not be shifting dullness on the left side of the abdomen, but it will be present on the right side. Okay, curve sign. Then we have balance sign, which is here it is, here blood is coagulated, left side. So we will have shifting dullness. Shifting dullness will not be there. Shifting dullness will be there. Dullness will be there because blood is not coagulated. This is balance sign. Then we have curve sign. Then we have latent period of Randet, wherein the omentum, greater omentum initially seals off the tear. Okay. Seals off, which later opens and develops shock. And shock. So this that period 10 minutes. Then there is delayed shock in case of pancreatic enzyme causing this one. Patient will also present with shock. So in shock we'll have anemia, tachycardia, hypotension, hypo BP, cold, clammy skin, guarding rigidity. Okay, so all of these are clinical features of splenic rupture. Very important, grading of splenic rupture and management of splenic rupture. So etiology, cause is blunt trauma, penetrating trauma, spontaneous and iatrogenic. Okay, rupture of spleen can be a question long ago asked, but okay, fine. I'm not expecting this question, so I'm not going to do it in detail. So I just do hypersplenism and I just do hypersplenism and grading and management of splenic rupture, and just the headings for this one, 10 marker of spleen. Okay, so in hypersplenism, what is hypersplenism? Where there is pancytopenia despite a normal or hypercellular bone marrow. Okay, this is usually involves red cell expansion. So definition from previous page. Then it involves red pulp expansion. Very important is in 15% of all cirrhosis cases, liver cirrhosis it is seen. Okay, anemia and thrombocytopenia are rare on this one. So the causes are tropical splenomegaly. Then we have myeloproliferative diseases. Then we have portal hypertension. Then we have Gaucher's. We have chronic hemolytic anemia. And we have inflammatory conditions like sarcoidosis and lupus, SLE and sarcoidosis. Infections such as, here this is important, infections such as TB, malaria, Kala Azar, brucellosis, hemolytic anemia such as hereditary spherocytosis, G6PD, thalassemia. Why do we not write sickle cell disease? Tell me that. Because sickle cell disease causes autosplenectomy. That is fibrosis of spleen, smaller spleen. Gaucher's disease, we have amyloidosis, neoplastic infiltration, portal hypertension, sinister hypertension, myeloproliferative diseases, and tropical splenomegaly. Tropical splenomegaly is malaria, kala-azar, schistosomiasis, you can write. Here, brucellosis, TB, malaria, etc., extra everything. It is a hypersplenism. And in hypersplenism, we do splenectomy only in cases of, yeah, we do splenectomy. So it improves the patient outcome. And you can write about splenectomy, it doesn't matter. Grading and management of splenic rupture. Okay, so what is the grading of splenic rupture? Grading we have 1 to 5. This is the most important grading. 1, 2, 3, 4, 5. 5 completely shattered spleen. Your segmental vessels gone. Here it is less than 3 centimeter depth. Less than 1 centimeter depth, 1 to 3 centimeter depth, and greater than 3 centimeter depth. Then less than 10% surface hematoma, less than 10% of subscapular surface area, 10 to 15% of subscapular area, greater than 15% of subscapular area, segmental vessel injury. Fine. What is the management? The management of splenic trauma is, yeah, grade 1 and 2. I just refer, it's a very nice, this one, refer book on it. It's a very nice diagram. As a diagnostic peritoneal lavage, you'll learn in this one, don't worry. Uh, yeah, you can draw this. Grade 1, grade 2. Various grades of splenic injury diagram you can draw. This diagram of page 691. Yeah, management we have to do. Management. Sorry, yeah, management grade 1, grade 2, if the use usually stable, investigation of choice CECT, conservatively managed, wherein what and all we do, monitor vitals, hematocrit, and 24-hour repeat CECT. Then, if the grade of injury is increasing or there's contrast blush CT, what we do is hemoglobin we check, 4-quadrant tap aspiration, emergency ultrasound, diagnostic peritoneal lavage, DBL, plain X-ray. Yeah, we do angioembolization. Angioembolization if the grade of injury is increased or there's contrast blush CT. If despite doing this, it is the patient is still unstable, we do surgery. What is the surgery we do? We do splenography, wherein the preservation is a small tear is sutured using chromic catgut sutures. We suture it. Preservation is done. This one, splenography. Or we do partial splenectomy. So partial splenectomy, it can be done because the splenic artery gives an upper pole branch and a lower pole branch. Hence, when one of the branches is ligated, the bleeding stops and partial splenectomy can be done. The spleen can be cut into multiple pieces and can plant it within the greater omentum. The spleen survives because of neovascularization, functions like a spleen. Is implanted within the greater omentum, functions within the spleen. Okay, that is splenic preservation. Then we go for if the patient is third stage, fourth, five unstable, then we do FAST, that is focal assessment sonography. Uh, FAST is done, 4-quadrant tap is done. And we do splenectomy, emergency splenectomy. This is done, plus that four headings from page 693. Okay, good enough. Good enough. Yeah, so management, diagnosis, clinical features, only etiology and surgical anatomy is remaining. So, in surgical anatomy, we have spleen, parenchyma, blood, this shit, that shit. Spleen is an organ, 9 to 11th rib, 135 centimeter. It's undersurface of diaphragm. Anterior border is notched. Yeah, let's just draw this, okay? So we have ligaments. We have phrenicocholic ligament. We have gastrosplenic ligament, which has short gastric vessels. We have two avascular ligaments, that is splenophrenic ligament and splenocholic ligament. Then we have a lineorenal ligament. So yeah, those are the ligaments. It has a notch, and a splenic artery and all is related to the upper border of the tail of pancreas. Uh, yeah, and there are two types of distribution, magistral and distributed type. Distributed type, the blood vessels divide away from the hilum. See, this is important in case of partial splenectomy, okay? Okay. Uh, Artery divides close to the pole of this one. So this much is enough for surgical anatomy. There's nothing more here also. Lineorenal ligament, this shit, that shit. Highly vascular, red pulp, white pulp, blood supply, splenic artery, which is a branch of celiac artery. Okay. It divides into 4 to 5, this one. Two types of distributions. Lacerations of spleen parallel to result in minimal hemorrhage, whereas perpendicular causes more hemorrhage. Yeah. Then now we have accessory spleen. Spleen has an avascular this one also. Line you see. Venous drainage, splenic artery, superior mesenteric artery forms the portal vein. Lymphatic drainage. Yeah, what are the causes of rupture of spleen? Blunt injury, penetrating injury, blunt injury, spontaneous injury in cases of ruptured hydatid cyst, infective mononucleosis, malaria, iatrogenic during surgical procedures. Blunt injury, road traffic, cricket, this shit, penetrating injury in case of the stab and all. So we can have a subscapular hematoma, clean injury in operations, lacerated injury, blunt trauma, hilar injury, avulsions and trauma, blunt trauma, and splenic injury. Okay. So this about covers it. I will also write to just briefly flip etiology and splenic anatomy for 10 marker. Okay, so this covers spleen for us, and see you on the next session.